All right, so welcome to our first general meeting for this cycle. Um, let's get started with introducing the new board. All right, so I'll be the president for this upcoming year. And essentially my role will be kind of overseeing everything, running these general meetings and just making sure everything's kind of running smoothly. And I'll be here to help, with everybody's position, to help with the analysts as needed. Tiana?
Hi guys, I'm Tiana. I'll be the vice president this year. My main role is going to be assisting Samantha and make sure that everything runs smoothly. You guys are always welcome to message me and reach out if you have any questions about anything. I'm here to help.
And our treasurer Marcos couldn't be here today. He's actually at the AAN conference right now. He was presenting a poster there. So I'll just kind of talk a little bit about Marcos. So he's MS4 from UMHS. And he'll be our treasurer for this upcoming year. So his main role is going to be to, look for funding opportunities and deal with everything financial regarding our group. All right, Miranda.
Hi, I'm going to be the operations manager. So what that means is I'll be making sure the website's up to date. I'm going to be helping with social media aspects, and then as well as being on the e-board, I'm an open book. If anyone has any questions, please just message me. I'm very easy to get hold of. Speaking of the website, though, real quick, if everyone here, if they could send their photo that they would like put on the website, what school you go to, and then what field of medicine you're the most interested in at right now. I'll put that on the website so that all your profiles are updated on there. But thank you so much.
Thanks, Miranda. Alexis.
Hi guys, I'm Alexis. I'm an MS3 at Ross. I'm going to be the secretary for this year. My hair looks a little different, obviously, than my photo. It's a little outdated. Sorry about that. I haven't taken headshots until recently. But my main role is going to be, as secretary, is going to be taking attendance and also taking notes at the meeting, sending out emails and all of that stuff. I am new to CRG, so kind of learning my way as I go, but I am very excited to be with you guys this year. I mean, if you have any questions, please reach out.
Thanks, Alexis. Danielle.
Hi, I'm Danielle. So I'm going to be the outreach manager this year. So my main role will be to keep current members, alum, and prospective members up to date on all things CRG. So projects, presentations, and conferences that we'll be going to and presenting at, and also just promoting CRG on social media. So if you haven't followed us yet on social media, please make sure to do that. Also, as Alexis said, I'm also new to CRG, so learning along with you guys, but also if you have any questions, feel free to reach out to me.
Thanks, Danielle. And Alex.
Hi guys, my name is Alex. I'm going to be the project manager. I'm going to be overseeing the project tracker, as well as trying to find opportunities for us to create projects on our own, as well as be the facilitator amongst other positions to help them with their projects as well. So if you guys have any questions with projects, please feel free to reach out to me. I'm an open book. Okay.
Perfect. So thanks, guys. On that note, we'll get started, and I think we're all on the same page with being open books, so just anyone can message any of us at any time if there's any questions. All right, so getting into the presentation for today, Dr. Javier Chambi Torres is here to join us today. So he's a PGY2 internal medicine physician, and he has an interest in cardiology. So he went to med school in Peru, and he's currently doing his residency at Larkin in Miami. So thank you again for being here with us, Javi. And if anyone has any questions, we'll gear them towards you towards the end. And on that note, Alex, you can take it away.
Okay, does it allow me to click right away?
I'm gonna do the slides. Is that okay?
Oh, okay. Yeah, that's fine. Okay, alrighty. So today's discussion is going to be about the effects of semaglutide on cardiovascular outcomes in non-diabetic patients. So I chose this article because I think it's a great field to get into. As we all know, semaglutide is one of those drugs that are very new. So this is the article that I'm going to be presenting today. It was published by the New England Journal. So it's a pretty big article, a pretty big journal to discuss. Go ahead. So the introduction. So as we know, obesity is one of the leading causes of death. It's associated with over 4 million deaths since 2015, and 2/3 of those deaths are due to cardiovascular disease. The treatment goals for cardiovascular disease to try to reduce it is to treat the dyslipidemia using things like statins, hypertension using things like ACE inhibitors and beta blockers, and diabetes using things like metformin, insulin, and a newer drug that we know about today is SGLT2 inhibitors. So the GLP-1 receptor agonists have already been shown to reduce the risk of major cardiovascular disease events in type 2 diabetic patients. So now we're going to be wondering, does it work for non-diabetic patients? Okay, and then this is an article that I found that I thought was really interesting that talks about the GLP-1 receptor agonist decreasing cardiovascular risk in the type 2 diabetic patients. So if you guys wanted to dive into that, I wanted to give you guys the opportunity to see the articles too. Okay, so what is semaglutide? So semaglutide is a GLP-1 receptor agonist. It has been shown to help patients with type 2 diabetes who aren't able to reach their target HbA1c goals on metformin alone, or if they have contraindications for using metformin, like things such as like renal disease, metabolic acidosis, I think like heart failure is one of them too. It's also used to treat patients with obesity. So the mechanism of action for semaglutide is that it delays the gastric emptying, inhibits glucagon production for pancreatic alpha cells, and it also decreases beta cell apoptosis while increasing proliferation. And the reason why that's helpful is because, you know, as you're eating, you're not getting hungry as quickly, you know, so it increases your feeling of fullness longer. So it decreases like your caloric intake. Yeah, you're good. Thank you. And then the other known functions of semaglutide is that it improves your cardiovascular benefits by improving left ventricular ejection fraction, myocardial contractility, coronary blood flow, cardiac output, and endothelial functions. Other systems that it does affect as well is that it increases muscle uptake of glucose, and it's also neuroprotective. Okay, so contraindications or adverse effects from semaglutide. For pregnancy, they say that you should not be giving it to pregnant patients. So people who are trying to conceive or people who are currently pregnant should not be taking this medication. Oral contraceptives have also been shown to not be as effective in patients taking GLP-1 agonists. And that's due to the effect of the decreased motility and decreased absorption from the GI tract. And it has been shown to, and it does affect people who have severe GI diseases like gastroparesis or inflammatory bowel disease. Their GI tract is already, you know, has a lot of things going on. So giving them a medication that also affects that is not a good idea. On the right-hand side, I included a table that talks about the other smaller adverse effects as well.
Sorry, I think I unshared my screen. Can you guys still see it?
Yeah.
Oh, I can't. Give me 1 second.
Okay.
All right, there we go.
Okay. Black box warnings that you should be concerned about is that it has been seen in animal models or rodent models that it can affect your thyroid gland. It has increased calcitonin release, which is a tumor marker for clear cell of the thyroid, so medullary thyroid cancer, and pancreatitis as well. It has been shown to cause hemorrhagic or necrotizing types. So patients with a history of pancreatitis or patients who develop pancreatitis should discontinue the medication. Okay. Okay, so diving into this article, this is the trial population that we're aiming at. So patients 45 years of age or older with pre-existing cardiovascular disease and a BMI greater than or equal to 27 without diabetes, okay? I also included on the right-hand side the other baseline characteristics of the patients. And as you can see, it does seem like there is a pretty decent spread of the smaller characteristics as well. It is important to note the trial population that you use during research, because if your patient doesn't meet these actual criteria or the trial population that they use, then it may not be the best article for you to use to help differentiate what you want to do for treatment for your patients. Okay. Okay, so the methods, what they did was they did a double-blind study, and it was multi-centered, so they used a bunch of different hospitals, and they either gave people semaglutide at a dose of 2.4 milligrams or a placebo. With the 2.4 milligrams, they started them off at 0.5 and then slowly worked their way up to 2.4 over the course of 16 weeks. And then semaglutide was discontinued in patients who developed serious adverse events or patients who planned on becoming pregnant. So like I said before, the elevated calcitonin or pancreatitis, or if they, if they planned on getting pregnant, that they would use it. And then the cardiovascular efficacy endpoints that they described was death by cardiovascular causes, non-fatal myocardial infarctions, and non-fatal strokes as well. Okay. Okay, so the results of this case, they did it from October 2018 all the way to March 2021, and they had a total of 17,604 patients, which is a pretty decent amount. They had about a pretty even split between the semaglutide and the placebo group, and the cardiovascular endpoints were about 6.5% in the semaglutide group, and the placebo group having an 8%. That gave us a hazard ratio of 0.8 with a 95% confidence interval of 0.72 to 0.9, and a p-value very, very significant, less than 0.001. Okay, so in the discussion of this article, what they wanted to do was to figure out whether or not this actually did help with patients without diabetes. Does it decrease the events of cardiovascular disease in patients without diabetes? And as you can see, the statistics showed that it did. It also showed that it did decrease the body weight and waist circumference, which, as we know of semaglutide, it is supposed to be like a diet medication. So we were expecting that to happen. And then the patients on semaglutide did experience some GI symptoms, things like nausea and vomiting. And they did have a higher incidence of gallbladder-related disorders. And as we know, having a significant decrease of weight does give you a higher chance of developing gallstones. So, that is the hypothesis of the gallbladder-related disorders occurring. But we did notice that life-threatening adverse events between the two groups wasn't that much different. Oh, someone wants to get admitted. Should we let them in? Yeah, okay. Alrighty. All right, so the mechanism of cardiovascular risk reduction with semaglutide was hypothesized that it was due to either the reduction of excess abnormal body fat and weight, which has been shown to decrease or improve glucose control. It did decrease the ectopic adipose tissue as well, which may contribute to the atherosclerosis or heart dysfunction. And it was a anti-pro-inflammatory, so it decreased the inflammation within the body. It also decreased the risk decreases of perivascular epicardial adipose tissue as well, so it improves the function of your endothelium and myocardium. And then we did see in animal studies that it did reduce inflammation, improves endothelial and left ventricular function, promotes plaque stability, and decreases platelet aggregation as well, which I did mention earlier. Okay, so one of the big things, and this is a topic for further research in the future, is whether or not semaglutide can replace bariatric surgeries. So as we know, semaglutide, is just a medication as opposed to bariatric surgery, which, involves, going under anesthesia, removing parts of your GI tract, or even like redirecting things. So there's a lot of risks that come from the surgery itself. So, if we can treat people without using a bariatric surgery, that's a plus. So as we know, obese patients have a decreased risk of cardiovascular disease if they lose about 10% or more body weight. And with bariatric surgeries, it shows that we lose about 20%. So good, right? So now the next research topic would be to decide whether or not semaglutide therapy can get us those same results without having to put people under for surgery. Okay. Other trial findings that were found was that it improved other cardiovascular biomarkers, such as blood pressure. It decreased the systolic blood pressure by almost 3.3%, or 3.3 millimeters mercury. And a decrease in systolic blood pressure leads to a 7% decrease in vascular mortality. So it's very important to try to control people's blood pressure if you're trying to reduce the risk of cardiovascular disease. It also decreased their waist circumference. Glycemic control was improved, nephropathy was improved, lipid levels were also improved, and C-reactive proteins, which are another inflammatory marker, were reduced by 37.8%. So all very good things to see. Okay, so talking about the recommendations, current recommendations for the use of GLP-1 receptor agonists are for patients with who need a cardiovascular risk reduction and weight management in diabetic patients. The trial results would be to, sorry, my screen's blocking my words. The trial results that we found is that it could also help patients who are not diabetic. So, now that we have this type of information, we could start to justify the use of this in non-diabetic patients as well. And then another finding that we found in this article was that 2/3 of the trial participants had dysglycemia. It wasn't enough to be diagnosed with diabetes, but they did have, some signs of pre-diabetes. So trying to decrease that risk is also beneficial for trying to prevent the risk of cardiovascular disease.
All right, so that's it, right, Alex? All right, so does
Yeah.
anybody have any questions for anything we talked about? Dr. Chambi, do you have any comments or questions?
Yeah, it's a very interesting clinical trial that is trending right now, like all these drugs, semaglutide. I see them being used in the clinical setting, but also in the as over the counter. Anyway, some points that I want to highlight here. It was a very good presentation. When you analyze a clinical trial, it's a very important way to create a high-level evidence in medicine. It's very different from doing, for example, a cohort study, a case control study. And why? There are different factors that are assessed. For example, in this article, it's regarding the validity. When you can say that a study is valid or not, is when the authors assess or take into consideration different points, like, for example, confounders. One way to assess confounders in a clinical trial, and one of the most common used, is when you have a study that is randomized, as this one. This one was randomized. They use a double-blind, a placebo-controlled trial. That's a gold standard for clinicals, for trials. And for example, this is more related to methodology, but because this is a research group, it's going to help you a lot to understand how important it is. When you randomize a population, that helps to distribute the known and unknown confounders that can be present in those groups. So when you by blinding, you minimize the bias from participants and from researchers too. That's one thing. Another thing that helps in the validity of this study was that you mentioned that they had like 17,000, right, population. That's also this large population is also very important because of the power that is given to the results. And that helps with the generalizability of the study. The only downside here that I could see in the table that you presented is that it was more related to, here, like in race or ethnic groups, like 83% were white population. So that can affect the generalizability. That could be a downside. So when you talk about validity, you have to talk about internal validity and external validity. So internal validity is when you say that how accurate your measures are, the effect of intervention, how accurate it is. For that, randomization and blinding helps. Also, control of the confounders help. Another factor that influence here is the follow-up. They did an extended follow-up. That's very good. And external validity is what the word that I mentioned before, generalizability. Is like the study results can be generalized to other populations. In this case, one point in favor is that there were 17,000, approximately 17,000 population. That's a large population. Also, I read that it's from different countries, like 40 something countries. So that's a point in favor. The downside could be, as I said, like underrepresentation of other races. But anyway, that's a good point. The other one is the relevance of the clinical practice in the case of external validity. Assessing these new drugs in something so common nowadays, like obesity, it's very important, it's relevant. Also, this study had a well-defined, they defined very well the inclusion and exclusion criteria. What else? That's it, I think. Very good presentation. I don't know if you have any questions or any other comments.
Thank you,
Thank you,
Dr. Chang.
Dr. Chang. I saw that someone had a question. I think it was Julia.
Yeah, I actually did. I thought it was a very good presentation, super interesting. As a person who might be interested in endo, I've had conversations with multiple physicians with the use of semaglutide in patients that have obesity, and a lot of my patients on the floor. I just got done with my IM rotation, where on semaglutide, and they fell within the same qualifications, but they were diabetics. So my question, I guess, is, I mean, obviously we're students and we're all like learning together. So it's like, how do you guys think that the results of this study can like influence the approach of primary prevention in cardiovascular disease, especially in patients with obesity? So what I'm basically thinking is like, we know that obesity is a major risk factor, like you mentioned, atherosclerosis, but there's also like other factors that play a role with other comorbidities, like does the patient also have hypertension? Do they have a strong family history of diabetes? Because we know obesity very related to diabetics, like you said, with the pre-diabetic population. So yeah, what do you think about that?
I mean, I think that this type of studies will, be very beneficial for clinical use in the future. I mean, I believe that they're already using it for the most part. So yeah, I think it'll help, change a lot of lives for people, not only for cardiovascular risk, but, patients who are like really struggling with their weight, like mentally and physically having to deal with like, extra weight all the time. Being able to have access to this and have, reasoning to give it to them, like, oh, like not only is it going to help them lose weight, but it helps prevent cardiovascular disease. Like I think that'll be a very big plus, and it may like decrease the like negative connotations associated with like fat loss supplements and stuff like that. So like maybe soon it won't be known as like the fat loss supplement, it'll be like the anti-cardiovascular disease supplement. And I think that may help people be more inclined to try the medication and change their lives. Dr. Chambi, you feel free to barge into that one too.
Yeah, like methodology-wise, the next step here, I don't know if this is the only trial that was done regarding semaglutide in this population, but for to increase the evidence and be more applicable in the clinical setting, the next step in evidence, in the level of evidence, is to do systematic review. It's in general terms, it's like systematic reviews when you create a structured approach, when the authors review and they synthesize the research evidence of a particular topic. Like, for example, if any of you guys or group of you wants to create a stronger evidence regarding this specific topic, that's a good way to continue. Because a systematic review, it has a predefined protocol, it minimizes the bias way more. Those are the benefits. It minimizes the bias. The quality assessment is increased. And also it helps the systematic review in general. provide a robust evidence base for developing clinical guidelines too. That's in general terms other definition that is important for you guys to know what is a systematic review and what it implies. That's in general terms.
I had a comment too about something you mentioned, Alex, like kind of switching the dynamic between like from it being like a fat loss supplement to like a decrease in cardiovascular disease, drug. Because I feel like there's so much controversy between like Ozempic use and stuff like that, and like celebrities and like people who just like want to lose weight and don't really need it. So like that would just be like imperative in just making that change in dynamic, having more research published and having this more like advertised as like something to reduce cardiovascular disease incidence, so that maybe there's not such a kind of negative connotation to using this drug. And so yeah, things like doing research and just like us knowing as future providers that like this is like another positive of using Ozempic. But then it also kind of brings about like there's still like a shortage, right? So it's like, well, is it going to help the people that with obesity more or the people with diabetes more? Like who needs it more? Like that kind of thing. Like where should these resources be allocated? So like I guess that's something that, I mean, that's totally out of our control, like supply issues and stuff like that. But yeah, I just thought that was like an interesting point that you brought up.
Yeah, that was what I was trying to go for when I was asking about primary prevention of the cardiovascular risk. Like, are we going to start using it as like anybody who's obese or at risk of getting cardiovascular, just like put them on like semaglutide or like the new ones like tirzepatide, which is advertised as Mounjaro, that everybody's starting to get on. So it's just like a big question as to how it's going to affect like our standard of care, because there's way more factors that go into picking semaglutide versus tirzepatide versus going with the standard, which is like orlistat or naltrexone bupropion like combination like medication. It's just like a whole like list of questions. And I agree with Dr. Chamby when he said that a systematic review could play a good role in seeing more of the evidence and long-term consequences of using these drugs.
Well, hey, we're a research group and that sounds like a great topic. So, if anybody wants to like put something like that together, and Dr. Chamby, you can, be a part of that as well. We can talk more about that like later. You guys can think about it, but yeah, that's what we're here for. Like something like that would be a great topic to dive into. I see a hand. Siham?
Yes. And I think based on that, it would actually be kind of cool to see what like maybe like specific subgroups within like a population that would show like more pronounced cardiovascular outcomes, like people with maybe like a higher baseline, higher BMI, or those with like more severity of cardiovascular disease, age, sex, because I know that Dr. Chamby mentioned with this one that the population here was mostly Caucasian. And so it'd be interesting to see with like more research or anything anyone here does to see if it would be like, yeah, more pronounced in any sort of subtype group. I guess that was more of a comment than a question, but unless it did say somewhere in there that it was more effective in a specific subtype, but
I don't think I recall it saying anything like that. I'll look over it again and maybe I could like send a message out if I do find something. But no, you did raise a good point, and Dr. Chamby did too, in regards to the different race and ethnic groups that are associated with this trial. As we know, obesity doesn't only affect the white population. It typically affects people in like the Black population as well. So increasing those numbers I think would be very beneficial for the use of this medication in clinical trials too.
Hey,
Right.
Alex, I had a question. I don't know if you can answer this, but there was You mentioned that there was like people that had to drop out because either they were getting severe side effects or wanted to get pregnant. I forgot which slide that is. But do you know, did it say how many
Yeah.
people had to drop out of the trial?
Oh man, that's a good question. I think that it actually was there, but I didn't include it. But I still believe that they included them in the data with like the intention to treat method.
Okay.
Yeah, I'm not sure though. That's a good question.
All right, no problem. Any other questions, guys? Comments?
I wanted to just have a brief comment. The first one is that you made a good point at the end about GLP-1s versus bariatric surgery and which one will be more beneficial. I think it's going to be difficult to say, especially because semaglutide and all these GLP-1s are so expensive monthly. So it's like I remember I did an endo rotation, and we had a patient that because of insurance lost their semaglutide, and usually that company sort of like gives some coupons so that the patients can get more at a discounted price, and then the discount sort of like ended on that month, and she had a ridiculous rebound of weight gain. So it's a really good it has to be a long-term comparison in which of the two are going to be very beneficial in terms of the long term. So that's a really good point. The other thing that I was trying to, when I looked at this paper, I was trying to be as critical as possible, but it's really hard to be critical of a New England Journal with 17,000 patients. But the one thing that I was thinking, maybe it could be done for the future, for future research, is they were comparing GLPs with the placebo. And I was just thinking, in theory, if I was a patient and I get that automatic weight loss just because of the delayed gastric emptying, could a couple of patients have like a positive reinforcement that I'm losing weight? Okay, so I'm losing weight. Let me do more exercise and let me change this diet in comparison to people that are not getting the placebo. So I think it would be a really good bias if the data was not that large, but I think that a good future research would be to just compare this semaglutide with another GLP-1 that does not have any cardiovascular modifiers, just in the future, just to see that it's not because of that weight loss, in comparison to the placebo. And the other thing that I wanted to ask, and this is for you, Alex, and for Dr. Shambi. There's a paper that came out a couple of months after this one. I think it was in April. It was a systematic review for treatment for type 1 diabetes patients, and they mentioned this paper because of how big it is. And my question is, although it doesn't have any indications for type 1 diabetes because of the first of all, you're not giving insulin, you're just the gastric emptying. But would you give, even though it doesn't have a proper indication, would you give the semaglutide to a person that's type 1 diabetes that, as we know now with the data, they're sort of getting into the same weight in abdominal, the same basically metabolic diseases and symptoms that patients without type 1 diabetes are getting? Would you give a semaglutide just for the prevention of cardiovascular disease, knowing that you can trigger a possible hypoglycemic event?
Again, that's a good question. Maybe when I'm a full doctor, I would have a better answer for that. But to my knowledge, patients who are like type 1 diabetics are, one, like typically found earlier in their lifetime. Two, they're typically not like the obese population. So maybe using a drug like this may not be the best use of it. This is just my novice medical student, opinion on it. But you never know. I would be a little bit afraid of that too, using something that could, decrease their caloric intake on a patient who already may have like hypoglycemic events, So yeah, it's a good question. I'm not super sure.
Yeah, exactly. No, as a doctor, I will be careful if there is no evidence that can back that we'll be careful because of the adverse effects that they can have in a patient. Like if I don't have any evidence or any studies that can tell me, okay, it's safe and the benefits are gonna be more than the injuries or the adverse effects, I would be very cautious on doing that in a population that has not been studied. I don't know, I didn't search if there are studies of semaglutide in type 2 type 1 diabetes patients. I don't know, but also as you mentioned, type 1 diabetes patients, usually they are not obese. So, but in the cardiovascular wise, yeah, that would help. But as I said, if there are no studies or trials or systematic reviews, as a doctor, I would be very cautious to prescribe that because remember, the benefits have to be more than the side effects of any drug.
Melissa, did you want to add something or do you have another question?
Yeah, I don't think I have a question. I just wanted to add on to what Jose was saying, with rebound. And then that kind of ties into if you wanted to have a control group that's taking a placebo and one that's taking like semaglutide, with GLP-1 agonist, or you're going to have weight loss regardless. And a lot of doctors that are working with patients with obesity that want to use these drugs, they're being used as tools. So you almost want to have like a patient population that are going to have some sort of diet or lifestyle change with their diet, so they can, one, kind of compare the similar groups with and without the drug, but also for patients who do lose weight so they don't rebound after. Because I mean, this is just like my opinion, but it's probably because of lifestyle changes that people keep it off after getting off the drug versus gaining weight back. It's like similar with keto. People that do keto, as soon as they introduce carbs again, it's like overloaded and they gain everything back. But
Yeah, that's definitely a challenge with being a practitioner. Like honestly, anybody like in the healthcare field at all, just like getting people to put in the effort and like make those lifestyle changes and diet changes. Like those are the hardest things to stick to. And like definitely things like this can like help. But we all know like what's the first thing we always say is diet and exercise, you know. That's the hardest thing to stick to.
Yeah, so I don't think I have a question. I just kind of wanted to add on to that it would be a cool comparison with both groups actually actively having kind of diet change in order to lose weight, and then seeing how that helps with everything else as well.
Yeah, good point.
Sorry, I can't actually figure out how to raise my hand for some reason in this. So I'm raising my hand physically. Another comment that just popped into my head as well, with you were talking about people who might rebound after having these medications. I just thought about economic groups. So if they're in like a low income area, that might be hard for them because they're not able to have access to, I don't know, healthier, cleaner foods to be able to maintain that weight loss. So that too could be another like breakdown of how you could do like a systematic review or articles kind of looking at that as well. Like, I feel like those are also big factors that would play into this.
Yeah, 100%. That's always an issue as well with healthcare and stuff like that. Which sorry, I forgot who brought the point. I think it was Jose who brought the point up between like bariatric surgery and and the semaglutide for like long-term use because of the cost and stuff like that. Ivy, you also have your hand up, I could see.
Yeah, I finally figured it out because I was struggling to figure out how to raise my hand for like 5 minutes and I didn't want to ask for help.
Oh, that's so funny, guys. You could just like unmute and talk. Don't worry about it.
I had a question because I don't know if I was reading wrong, but you mentioned somewhere in the slide something to do with like the GLPs affecting pregnancy. But haven't you been hearing like a lot of women coming out saying that while being on like Ozempic, they've like and they're on OCPs, they're still getting pregnant? I'm trying to understand if that's what you're trying to imply or. Oh, yeah, you have it
So
right down. Okay.
yeah, so in the slides, I talk about how some contraceptive use is contraindicated with GLP-1 agonists, and that's hypothesized that due to the decrease of gastric motility, they're unable to like absorb the oral contraceptive properly. So it increases the risk of still getting pregnant, even though they're taking these oral contraceptives. So switching to like an injectable or like an IUD on a patient who has GLP-1 agonist use is, you know, the general idea of like what you should be doing for these patients.
Okay. All right. Thank you.
Mhm. Did that answer your question?
Yeah,
Was
it
that-
did. It did. Sorry, sorry, I
Okay.
said something else, but no, you're right. Thank you.
Yeah, yeah, of course.
Any other questions, comments? All right. Well, that was a great presentation, Alex. Thank you so much, and a great discussion from all of you. And thank you, Dr. Chamby, for your input. We appreciate it and answering our questions, you know, giving us a little biostats review as well. It's always high yield. So yeah, honestly, if you guys are interested in doing like a lit review on this topic, like that's definitely something we can put together. I mean, we can sort out the details with, you know, how many people we want on that and stuff like that. If anybody has time to like lead that sort of thing. And we can get Dr. Chamby involved as well to get more of his input. Dr. Chamby, would you be open to doing something like that with us?
Yeah, sounds great. To be honest, I was just searching right now in my phone, and there's systematic review already about semaglutide. They did it in obese patients for diabetes. But I mean, for sure, I'm prone to do a systematic review with any of you that are interested. We just have to sit and discuss about it.
Awesome. All right. We will be reaching out then
Yeah.
if we can get something together. So thanks again for joining us today, Dr. Chamby. And then for the rest of us, we'll stay on to do the rest of our sort of housekeeping things.